is a really fascinating area for our field because it does also represent the most important challenge that we need to overcome in order to ensure that patients that are eligible for therapies like thrombolysis or thrombectomy get it in time. And I do think that we've done a good job organizing our systems of care in North America and increasingly in Europe, but in much of the rest of the world, people who need these therapies struggle to access it. Part of the issue, sure, might relate to people seeking help on time, but I think that with better awareness campaigns, fortunately, more and more of the world are realizing that with stroke, you need to seek help quickly in a timely manner. So then it comes down to what do we do when we get that call for help? And the pre-hospital systems are currently relying on mostly kind of examination-based techniques, right, to identify whether somebody's potentially having a stroke based on kind of obvious signs of speech issues or motor issues or weakness. But I think we are moving towards a future where that's probably going to be aided by technology, so that even if, say, the paramedic that's seeing the patient doesn't have as much of an exposure to stroke, they can still be aided by different techniques, whether it is an AI listening in or whether it is some sort of detector that you place on the patient's scalp using EEG or TCD or other types of techniques to identify those patients that probably have a major vessel occlusion that need to be urgently transferred to a stroke center. I think there are fascinating developments happening in that area. The other part of it that also becomes important, the pre-hospital space, and are quite compelling to think about in light of recent trials like Frontiers, which involved giving a putative neuroprotective agent, neranetide, in the field, right? That also opens up a whole new vista of what are the things that we can do to protect a patient's brain while they're in transport so that we have more of it to save for consideration of thrombectomy or thrombolysis or these kinds of things. And then once a patient arrives in hospital, I think that one of the most interesting spaces now is the AI-aided analysis of imaging, because we have to acknowledge that for a lot of frontline physicians that don't have specific training or expertise in stroke, it's not feasible for us to expect them to be able to quickly assess imaging and identify, patients eligible for therapy in a time-sensitive manner without, say, waiting for a radiologist's interpretation. And I think that these AI-aided algorithms, imaging analysis algorithms, and there's so many of them done by so many companies out there, they'll help us ensure that fewer of these cases are missed and that people are alerted and notified in time. So I think it's a very exciting future ahead for triage and identification of patients. But at the end of the day, just like we've talked about with discussions about pre-stroke dementia, pre-stroke disability, there will be nuances to consider in the patients that we're thinking of treating. And in whatever mechanized, artificially intelligent future we're living in, that conversation between patients, physicians, and families will probably still be quite important at the end of the day.